Welcome, everyone. We're just going to give a second for everyone to join. As you can see, I am not Winnie Dixon. Winnie had some technical difficulties on her side, so I am pinch hitting for Winnie. Luckily for me, Winnie is extra organized, and so made it very easy for me to jump in. And this is the first time that I've really been on camera all summit. So I want to say an extra thank you to Renee, who has been an amazing partner in organizing the summit and has done so much. And I'm sad she's having some technical difficulties today, so she can't moderate this panel because I know she was really looking forward to it. But we're going to have a great panel, and I'm excited. Thanks everyone for joining. My name is Catherine Pugh. I am the Assistant Vice President of Policy at EHI. We have a great panel for you for the next hour or so. We joke that this is our most controversial panel name of the whole summit. The white male doctor will see you now, utilizing digital health to increase access to diverse providers. So for this panel, we're really going to focus on a very interesting aspect of digital health and health equity, which is the fact that not everybody has access to a cultural or linguistic appropriate provider in their communities. But through the power of digital health, we can scale those services nationwide and ensure that everybody can have access to a doctor that they relate to and that can provide the best possible care. So just wanted to set up the panel with a couple of comments here. First of all, cultural competency is recognized and as an essential means of reducing racial, ethnic stigma against marginalized groups and disparities in healthcare. It describes the ability of systems to provide care to patients with diverse values, beliefs, and behaviors, including the tailoring of healthcare delivery to meet patients' social, cultural, and linguistic needs. A culturally competent healthcare system is one that acknowledges the importance of culture, incorporates the assessment of cross-cultural relations, and recognizes the potential impact of cultural difficulties, expands cultural knowledge, and adapts service to meet cultural unique needs. And so I'm really excited. We have a great panel here, and I think every speaker in this panel provides a unique perspective, and each of their organizations is addressing this issue in a different way. So we're going to hear from each panelist. I'm going to introduce them now, but I welcome each panelist to share some more about yourself and your organization as we go through the panel. So first up, we are going to hear from Abner Mason, who is the founder and CEO of Conseil Sano, excuse me. Then we will hear from April Mims, who is the Senior Vice President of Public Policy of HIMSS and HERS. We also have Oliver Kim, who is the Director of Federal Policy of Cambia Health Solutions. And then Caitlin Johnson, who is the DVP Coordinator for the American Indian Health Service of Chicago. And so with that, I will turn it over to Abner.
Great. Well, thanks. It's great to be here with my fellow panelists, April and Oliver and Caitlin. Looking forward to hearing from you. So my name is Abner Mason. I'm founder and CEO of Conseil Sano. We are a health equity company, but the way we're addressing health equity primarily is through engagement, trying to build better relationships between basically healthcare consumers and the U.S. healthcare system. Maybe I'll just say a few words about the problem we're solving, and because it's a good way to understand who we are as a company. So the problem we're solving is that our country has changed pretty dramatically over the past 4 or 5 decades. We have become much more multicultural as a country. In fact, according to the last census, we're on the way to becoming a majority minority party. by majority minority country by 2045, and that's 5 years earlier than the previous census indicated. And certain states, like we're headquartered in California, Consejo Sano. I'm in Los Angeles today. California is already a majority minority state. So is Texas. The whole country is on that path. So the problem and this change is pretty dramatic demographic change that's happened in America. As you know, it has roiled our politics, and I think we're still trying to figure out how to come to terms with the country we've become and the country we're becoming. But for healthcare in particular, our healthcare system just hasn't kept up with those demographic changes. And what it means is that the healthcare system today just isn't well equipped to serve the country we've become, let alone the country we're becoming. And that mismatch between supply and demand, a healthcare system that isn't well equipped to serve the folks it's supposed to serve, creates poor outcomes for people, for healthcare consumers, and higher costs for society. Now, the way this problem has been addressed in the past and up until now, and this is the way it works across much of the healthcare system, it's what I call the old 1.0 model of patient engagement, which is all about language, taking the same sort of generic message, usually written by English speakers for English speakers, and then you translate it, and then you send it to all these new demographic groups. And that approach, sort of one size fits all, because it's the same message, just translated, usually not well, it just doesn't work. It doesn't build trust. And it's working less and less as we move forward, frankly, because people have come to expect better in other parts of society. They get treated better by Netflix and Amazon than they do by their healthcare system. And so what we've said at Consejo Sano is that approach, that one size fits all, it sends a clear signal to the consumer, who you are doesn't matter. Your life journey doesn't matter, because we're treating everybody the same, right? Your trust for the health system, your willingness to engage in healthcare, and really important, how the social determinants of health uniquely affect you, all the things that make you who you are. The way the healthcare system works today is we say, don't tell us, don't want to know, just we're going to treat everybody the same. And that's just not the way to build trust. And so what we're saying is let's move away from that and use technology and data to build a more customized, personalized experience that will build trust. And that's what we're doing at Consejo Sano. And key to our approach, and you can go to the next slide, key to our approach is that we think the way to do that is to understand who people are culturally. It's not about language, it's about culture. And we define culture as how people lead their daily lives, all those decisions and that influence how they're going to approach complex problems or even simple problems. That's what we call culture. And our view is that if we can understand who people are culturally and engage with them at that level, we will build trust. And that trust will allow us to then navigate them into the healthcare system at the right time and the right place. So we spend a lot of time thinking about culture and how it works. And so a foundation for us is this model of culture that was developed by an anthropologist called Edward Hall. And basically what you can see here, the key takeaway here is that the important stuff that really determines whether a person is going to engage, if they're going to trust enough to take that vaccine or to go to that doctor or to listen to that doctor, all that stuff you can't see by looking at somebody. You're not going to know it. And that we've got to figure out how to understand people at that level so that we can then connect with them in that deeper way to build that more trusted relationship. You can go to the next slide. So that's what we're doing at Consejo Sano. What we've said is, we want to be that health equity company based on culture. And for us, again, that means getting away from that one size fits all approach. Let's just stop doing that. We've got to stop treating people like who they are doesn't matter, and instead flip it on its head and engage with people like who they are really does matter. And we've taken the time to figure it out. You can go to the next slide. For us, the foundation is technology. You can't do this without technology. We're engaging today about 3 million consumers, and we're early as a company. Our goal is to go 10-fold, 20-fold this. We want to be engaging 30 million, 60 million people. So you can't do that. You can't build that kind of relationship without technology. So we're using technology to do that. You can go to the next slide. And when I say technology, we built a technology platform that allows us to reach people in a multimodal way at scale. But text messaging is definitely two-way text messaging is the way people prefer to communicate. The next part of this is how we talk to people. And we've developed a team of experts. Our company is composed of people who come from the communities we're trying to serve. For instance, our biggest footprint is Medicaid. We've got a lot of folks in our company who've been on Medicaid. We also are trying to engage people across cultures. So we've got a lot of folks on our team come from different cultures. If you look at our company, it looks like the United Nations, and that's by intention, because our view is that you got to walk the talk. If it's just talk, if we don't reflect the values we're trying to project, if we don't reflect those values, people aren't going to take us seriously, not going to trust us, not going to believe us. So we built a great team that's very diverse. They bring lived experience as well as academic experience. You can go to the next slide. And building on that foundation, we add in a layer of cultural intelligence. And this is all, mostly about data, social data, behavioral data, clinical data, cultural data. We collect a lot of data from every source we can possibly collect it from and ingest that into our technology platform. And that allows us to then do the kind of what we call cultural cohorting, or dividing the larger member population or patient population into much smaller groups based on culture. You can go to the next slide. And then on top of that, we add this cultural experience, again, bringing folks who have walked in the shoes of the folks we're trying to engage. And what happens when you do all of that, and you go to the next slide, you end up creating this culturally aligned engagement experience. And what we found is that this approach, and it does, it sounds, maybe it doesn't sound easy. Sometimes I say it and I think to myself, that sounds easy, but believe me, it's not easy, particularly when you're doing it at scale, serving millions of people, creating that more personalized, customized experience. We want to be better than Netflix and better than Amazon, because we think healthcare is actually one of the most important, things that we can deliver to people. And we should know them at that deeper level. This allows us to build a kind of trust that we can navigate people into healthcare at the right time, at the right place, regardless of what they look like, what they talk like, where they come from, or how much money they make. That's really our goal, is to have that more customized experience. So the final question I'm sure you'd ask is, well, does it work? And you can go to the next slide. And this is just one example. It definitely does work. This was a study done by UCLA of some work we did with a federally qualified health center, a large FQHC in Southern California. And FQHCs, they're safety net providers. They serve really low income people. They have a huge no-show rate. It's one of their challenges. And this particular FQHC, a huge number of folks who are Hispanic in terms of their culture, we started to deliver culturally appropriate text messaging, two-way text messaging. And when I say culturally appropriate, it's different for folks of Mexican descent versus folks who come from Argentina versus folks who might come from a different country that's Spanish speaking. So again, it's not about language, it's about culture. And what we were able to do was to dramatically reduce no-show rates, which was a huge benefit, not only to the FQHC, because they got paid when people come in, but also was a huge benefit to the patients who normally would have skipped that visit, whether it's a well child visit or a breast cancer screening or whatever it was, but we got them to come in. So the key here is, if you treat people like who they are matters, and you use data to understand that so that you can do it at scale, but you deliver that content, that message in a way that sounds personal, that sounds like we know people, you can connect, you can build trust, and that trust will then allow you to navigate people into healthcare at the right time, in the right place. We're proving that every day that it works. My only goal, one of my key goals here, is that we need to give every healthcare consumer this kind of experience, that people deserve to be treated like who they are matters. So with that, I will stop and turn it over to my next panelist.
Yes, thank you, Abner. We will turn to April Mims with Hims and Hers next.
Thank you, Catherine. And thank you, Abner. I follow you on LinkedIn. I'm a fan of your work. So it's such an honor to follow up. And it's also a challenge because you're a tough act to follow, but I will do my best. So I head up our public policy team at Hims and Hers. I also wear another hat, which is I'm a co-founder of our Telehealth Equity Coalition, which I'll talk to you a little bit about as well. Um, for anyone who's involved in public policy as it relates to telehealth, many of you know that the federal policy is critical, but what's also very critical is our state work. And so I head up a team that's really involved in creating telehealth policy for the 21st century, making sure that we're increasing access, especially for underserved communities, whether you're using commercial insurance, whether you're paying out of pocket, or whether it's with Medicaid populations. The Telehealth Equity Coalition and Hims and Hers, we're involved in those discussions. I also come to this conversation, not as a healthcare expert, but, wearing my hat as a person of color, a Black woman, a Black mother. And so as Abner was saying, I come with those lived experiences of being frustrated and even experiencing racism in our healthcare system and wanting for there to be change. And so, just starting with Hims and Hers, which is kind of part of my day job, Hims and Hers is a telehealth and wellness platform. The premise behind Hims and Hers is it's access to the best providers, from the comfort of your home or your car or wherever you might be with the touch of a button. And what's really allowed Hims and Hers to thrive over the past 5 years are really two things. The first is the proliferation of mobile technology, which Abner, you touched on. Many communities, even underserved communities, have access to mobile technology. The second is the proliferation of generic prescriptions. That marketplace has allowed for these types of prescriptions to be more accessible and more affordable. And so that's part of our commitment to equity. We also are involved in a number of other pillars that relate to equity as well. The first is, we are a dual language platform. We hope to learn more from our partners, such as Abner Mason's organization, and we're hoping to expand out to more languages in the future. The second that Abner also touched on is this concept of modalities. He talked about text messaging. For our organization, we are really committed to a type of modality called asynchronous. And asynchronous is essentially a telehealth visit that's not in real time. So if you think about it, maybe you're somebody who's a nurse who has not a very flexible schedule, or you work in ride sharing or some other form of platform where you're not around from 9 to 5, you're busy. Using asynchronous, you're able to start a visit at, let's say, 10 p.m. after you put your kids to bed. Perhaps the provider responds to you at 9 a.m. It creates this flexibility that's really helpful, especially for folks who have work or childcare schedules that are not very flexible. Also, for folks who don't have a high-speed internet connection, it's very helpful because you don't have to rely on that real-time synchronous component, which we know even for us who think we have a high-speed connection doesn't always work out. Some other things that we're committed to as well is this concept of stigma. That is a big part of our company ethos. And we know that, especially in underserved communities, communities of color, there still remains this stigma around getting access to healthcare, especially as it relates to things like mental health. And so we're willing to use all the tools in our toolbox, including humor, being very tongue-in-cheek, just to destigmatize these issues, to make it feel like a more informal environment and help bring people to the table. We think that's really important. And then the final aspect of Hims and Hers that I think is important to point out and is part of the topic of this panel is our providers. So according to some surveys that we did in April of 2021, we found that our contract providers, they work in platforms across the country, but they reflect in terms of their demographics, the US population. And so we're really proud of that fact. We know that there is a shortage of providers of color. I think I read a stat recently that said that just 5% and 6% of physicians are Black and Hispanic, respectively. So that's very important to us. And then finally, we know that over 70% of our contract providers are women. And so that's important as well as we think about inclusion and making sure that people have a provider that reflects their experience. Finally, we're very involved in making sure that we're training these providers, that they have sensitivity training and website manner, which we know is especially important when we're working with communities of color and other underserved populations. So that's a little bit about Hims and Hers. My other hat that I wear is I'm one of the co-founders of the Telehealth Equity Coalition. And, just to give you some background, flashback a year, it was right after the murder of George Floyd. We were in the throes of a pandemic. And I was on a Zoom call with one of my friends, Luis Belin, who heads up the National Health IT Collaborative for the Underserved. I believe he's on one of these panels for EHI, so please check him out. And we were really just talking about how we felt there was this real moral imperative to step up our efforts. You know, whether you're in the private sector, you're in academia, you're in an NGO, there was really this desire to do what we can to bring people around the table, to elevate these voices that have been working on many of these issues around connectivity and telehealth access for decades. And so we put together the Telehealth Equity Coalition with help from some other co-founding members. And as of now, we have over 130 members. We represent almost all 50 states. We've done 7 webinars, 3 policy papers, and a congressional briefing. And our secret sauce is really just harnessing the power of storytelling, which is both collecting data, as you pointed out, Abner, around social determinants of health, leveraging the stories of our members because they're doing such great work on the ground. And then also, you know, making sure that we're always keeping that local focus. I think oftentimes conversations around telehealth have to do with what's happening on K Street, what's happening in Washington, D.C. And we wanted to make sure the local voices, both government and non-government, were very much core and driving what our policy statements were. And so some of the topics that we have discussed and developed webinars and policy statements on have to do with the power of connectivity, the power of digital literacy. And one of my favorites, which you touched on as well, Abner, is trust and accountability, because as you pointed out so eloquently, so many of the barriers to healthcare are not physical, right? They're historical, they're psychological, they're in our DNA, they're based on these experiences that we've had. And so we really want to dig into that and see how we can use these local voices and spotlight them to try and make headway there as well. And finally, we are also involved in trying to see how we can advance policy to help digital health navigators, this concept, continue to be part of our part of the healthcare equity conversation. I think it's really the culmination of all the things we've been talking about. If you think about it, you know, imagine if you could have the support of a community member who's being paid fairly, who has the respect and trust of the community, and this person is helping you navigate healthcare tools. You know, it's really a great way to build in digital literacy, to build in trust and accountability, and to make sure people who aren't as familiar with virtual tools are able to have, get access. And finally, we're taking the burden off of our providers so that they can focus on being clinicians. And so really excited to see how we can partner with EHI on some of these initiatives, especially the digital health navigators, because I know that's been a part of some of the policy work that they are looking to advance. But overall, just really happy to be here and excited to be a part of this conversation. So thank you for having me, and I will turn it over to Catherine to introduce the next panelist.
Thanks, April. We will now turn to Oliver.
Thanks, Catherine. And thank you for inviting me to be here. And I think you'll also find a lot of my remarks parallel Abner and April in a lot of the thinking across all communities of color. We all have our unique challenges, but there's definitely some similarities. Just for way of background, I work as Federal Affairs Director for Cambia Health, which is a family of companies that includes regional health plans in the Pacific Northwest. And I also volunteer as the board chair of the Asian and Pacific Islander American Health Forum, long title, but we're a national nonprofit dedicated to reducing racial and health inequities that affect the Asian American, Pacific Islander, and Native Hawaiian communities, or which I'll refer to as AAPI throughout. Just for clarity, the views that I express are my own and don't reflect either. So as we know, there's a lot of online tools to help customers find a provider, you know, based on price, distance, those kind of factors. But we know that they aren't always the factors that our customers may want to look at to find a particular provider. So at Cambia, we've decided to try and look at our provider networks to give our customers the information they need to select someone based on comfort and familiarity, as well as those sort of economic issues. So trust, as mentioned before, is obviously hugely important in achieving good health. As you know, we may want to see somebody with a similar background and outlook, and that improves adherence and understanding. So we're building out a tool called P-Search using surveys of our provider network to give additional details for our customers in 4 areas: race and ethnicity, gender identity, preferred pronouns, and LGBTQ plus inclusive care. We just started this past summer, and we've already exceeded our initial goal of trying to incorporate this data for 25% of our primary care and behavioral health providers by this past October's open enrollment. And as of the end of October, we have this data for more than 40% of those providers across all of our markets, and we're on track to be at 80% by the end of this year. So we know the need is great, particularly as a consequence of this pandemic, but of course, from communities of color, this need to find culturally competent care has been longstanding and preceding COVID. One thing I wanted to touch on, it's not just for our physical needs, but of course, it's particularly sensitive for behavioral health. You want to be able to trust your provider fully, and often that means finding a mental health professional that understands your background and where you're coming from. So one thing that I recently blogged about for Health Affairs in the AAPI community, pre-pandemic, the utilization of mental health services was low for the AAPI population, just as it was for other communities of color. I mean, I think, as April mentioned, there's a shared stigma against mental health, unfortunately, that's too common. In the Asian American community, part of it, though, is also cultural. We have stoicism as a key virtue. Sometimes people refer to this as eating bitterness, but it's this idea of being able to endure hardship without complaining. And part of this also feeds into what's called the model minority myth around AAPIs, that we shouldn't complain about our station or status as a minority in society. The pandemic, of course, has brought additional stressors on all communities. And in the AAPI community, it's been a huge impact. According to a survey by the Health Forum, more than a third of AAPIs, particularly among adolescents and young adults, have felt their mental health had worsened since the start of the pandemic. And there's a few reasons, of course, why. One is that many APIs work in small businesses such as lodging, restaurants, hospitality that have been hugely hit by the pandemic and the need to socially isolate. And the second, sadly, is that we've seen an uptick in the attacks on the AAPI community due to the sort of racialization of COVID. Indeed, the amount and severity of some of these attacks, particularly some of the ones that have been horribly captured on video against AAPI seniors, has actually resulted in changes to federal law to better track and identify such hate crimes. So anyway, seeking support may be difficult for a group that has so many cultural barriers against mental health. So it's not just being, willing to utilize such care, but it's also, those basic questions. Where do you go? How do you find a provider? So that's why we feel tools like P-Search for culturally and linguistically appropriate care are so vital, not just for our AAPI customers, but for people of all backgrounds. Of course, there's only so many providers at any one time, and we're talking about even a smaller tool of providers here. Telehealth, as aforementioned, can really help improve our reach, but it won't solve all the infrastructure challenges like workforce and scope of practice and some of the public policy issues that the Telehealth Equity Coalition is working on. So another mechanism that we try and offer is, digital tools that can range from self-guided modules to meditation apps or meditation apps, sorry. And because these tools are online and often self-directed, there may be less stigma because you're using them, in your home or on your phone. There still needs to be trust. And so one thing I wanted to also note is that the Agency for Healthcare Research and Quality, or AHRQ, has a draft evidence guide up for comment on how consumers can best choose a mental health app. What are the things that they need to look for in terms of data, privacy, and security. So I'll end there with, obviously commenting that digital health alone won't solve all the issues, but it's going to be a critical tool in our toolbox to achieving better health. Thank you.
Great. Thank you, Oliver, for sharing your perspective from both organizations. And for everyone, the health affairs article that Oliver mentioned, I put in the chat box, so take a look at that. Now we will turn to Caitlin.
Good morning, everyone. I'm Caitlin Johnson. I'm a licensed professional counselor at American Indian Health Services of Chicago Incorporated. So it sounds like a lot of what I have to say today will be kind of supporting everyone else in the more administrative work, but I am a direct provider. Our clinic, we are an urban organization specializing in the care of American Indian and Alaska Native individuals. We have a medical clinic where we provide primary care as well as prescriptions and things like that, as well as a behavioral health clinic within the organization. And we serve over 150 represented tribes in Chicago. I'd like to start my portion of our time together with a land acknowledgement that our clinic currently sits on what was historically Kickapoo tribal land. Other prominent tribes in the Chicagoland area are Potawatomi, Menominee, and Ojibwe. I'd also like to acknowledge that I do not identify as Native, so anything I have to say is mine alone. But I am grateful for the opportunity to share my experience here at American Indian Health Services. My primary role here at AIHSC is the behavioral health care of survivors of domestic violence. In 2018, the statistics from the VAWA report say that more than 4 out of 5 Native women have experienced violence in their lifetime. I believe it was 85%. And 55% have experienced intimate partner violence. As of today, we know those numbers are much higher, especially with the rise of the MMIW movement. If you're not familiar with MMIW, I really encourage you to take some time to research it. It is an incredibly important topic when talking about the medical and behavioral health care of all Native individuals. MMIW is the Missing and Murdered Indigenous Women movement. For today, though, I'll be focusing on how the pandemic and telehealth in particular impacted our domestic violence counseling here at AIHSC. In Chicago, much like other communities, domestic violence cases surged because strengths that survivors were relying on were suddenly unavailable. This was especially evident in counseling. Something as simple as privacy might have no longer been available to survivors. So as clinicians, this changed the way we interacted with our survivors during sessions and in general. Safety planning was different, session content was different, and urgency was different. At American Indian Health Services of Chicago alone, our domestic violence survivors attending sessions doubled within the first year. One of the biggest disparities that the Native community experiences is the lack of culturally relevant care, just supporting everything everyone else said. Nationally, for domestic violence, there are only 56 shelters in the entire nation that have a Native provider available. And in total, there are only 257 Native service providers in the US, period, that specialize in Native care. The Strong Hearts Native Helpline, if nobody is familiar with that, is the only domestic violence hotline in the nation that connects Native survivors to Native specialized care. Native providers, as Oliver was just saying, are really important so that you can understand the background of where someone is coming from and increasing the comfort of survivors, but also increasing a willingness to share. In the Native community, there's a lot of gatekeeping that goes on, and rightfully so. But also not just for the comfort of survivors and seeking services, but also because of insurance limitations. Tribally enrolled Natives are eligible for all of their medical and behavioral health care services to be covered. All expenses are covered, including prescriptions, because they receive what's called IHS coverage. And only organizations funded by IHS are able to accept IHS coverage. So this severely limits Natives' access to healthcare, especially in urban areas. For example, Chicago has the 3rd largest urban population in the nation. And that's just in Chicago, not even in Illinois. But our clinic, American Indian Health Services of Chicago is the only clinic that accepts IHS coverage. So during the pandemic, when people are more focused on their physical health and behavioral health, our healthcare clinic moving to telehealth was able to reach more people, especially people that don't want to come into the city, don't want to drive into the city, who might not have access to the city with public transportation during the pandemic and things like that. So we were able to reach a wider native population through telehealth. But as I was saying, that also brought some other restrictions and concerns with telehealth, especially when it came to domestic violence. If there was an emergency here at the clinic, we would know where to send help. That might not have always been true for someone receiving domestic violence counseling via telehealth. So that looked like changing our safety planning, having a list of addresses that are most common or most popular for that person to be at, so that we would know where to send help if that was necessary. That looked like creating a safe word, right? Of like, this word means that I'm not able to talk right now. I have no privacy, and I need you to pretend like you're not my counselor. And another safe word saying that that I need you to call 911 and send help immediately. And we did have many of those, unfortunately. So telehealth has helped us to increase our reach to the rest of Illinois.
Great, thank you, Caitlin. Those are really powerful comments, and something that I don't think a lot of us think about on a day-to-day basis. So I really appreciate that insight. And like I said at the beginning of the panel, I think all of our panelists really made us think about this issue from every single, maybe not every single, but a lot of different takes on this issue. So I just wanted to kick it off with a few questions, and then we will turn it over to audience Q&A. So if anybody in the audience has questions, you can use the Q&A box, and then I will look there when we turn to the audience Q&A. But just wanted to kick it off with a general question to all panelists. So I think throughout this whole summit, something that we wanted to touch on is the promise of digital health to bridge barriers in the traditional health system. And so all of our panels kind of touch on a different way in which digital health can do that. However, I think we also need to recognize, which I think a lot of our speakers are, that there are issues with using digital health tools for many populations. Digital divide, access to affordable high-speed broadband services, and then of course cost, which Caitlin, you just brought up, cost related to uncovered services or out-of-pocket costs, even if you do have insurance. And so I don't want to ignore those very real barriers, but I would like to ask each of you to kind of touch on how your organization is, we all call for more broadband, more coverage for the patient populations. But in the meantime, how are you all addressing these issues? So first, Abner, since I see you're unmuted, I will turn to you.
Sure. So thanks for the question. I think one of the key things that we're doing at Consejo Sano is we assessed where the folks that we engaged with, what they prefer. And our biggest footprint as a company is in Medicaid. We serve about 3 million healthcare consumers today, mostly in Medicaid. We also do Medicare Advantage, but our biggest footprint is Medicaid. And as you know, that's the program for low-income Americans. We surveyed and said, how do people want to engage? And they prefer overwhelmingly text messaging. If you ask, almost no one said U.S. mail. So all the healthcare, all the health information, the plans, and who are mailing stop because people don't want to engage the U.S. mail. Even email is not very popular now with at least with Medicaid populations. what they prefer is text messaging, and that's true. And actually, it's not just Medicaid populations. If you look at other parts of society, text messaging is preferred. And so, one of the key things we're doing is we are helping our health plan partners to use text messaging to engage their members. Believe it or not, most health plans today still don't use text messaging to engage their members. There's a whole host of reasons, which I won't get into. Some of them are policy, but we believe that it's important to prioritize the patient and that we should engage with the patient in the way the patient prefers. And that if policy doesn't support that, we need to change the policy, not ask the patient to be different. And what we've been doing in the past is saying to the patient, well, you need to be different because, the policies don't let us do this. We've got to fix the policy. So we're helping our plan partners to engage via text messaging. And then the one other thing I'll touch on is we're also helping to highlight this issue of virtual care and low-income people. Pre-pandemic, fairly qualified health centers weren't reimbursed for virtual visits based on policy. You had to actually come into the clinic. Even though telehealth and there's all these new beautiful solutions, some of which are represented here and that you all work with, they only apply to higher income people. Lower income people couldn't use them, including telemedicine. And so the pandemic came along and they changed the rules and said, okay, it's an emergency. We'll finally let low income people benefit from some of these new technologies. So, which is great. So, let's applaud that. But two things, we shouldn't go back. Once the pandemic ends, we shouldn't go back to the old policy of saying low income people shouldn't benefit from the innovative solutions, healthcare solutions that are being developed, including all these virtual care solutions. So let's not go back. And then second, let's not prioritize one form of communication over another. And there's already this idea that if it's synchronous video, it should get reimbursed higher than, for instance, asynchronous or even telehealth, a phone call. What we found with Medicaid folks is they prefer phone. And even though a lot of providers say, well, I'd much rather have video. I think video is better. And so there's this sense that we should, again, prioritize what other people want as opposed to the patient. I'm not saying video isn't great. It is great. But if people won't use it, it's not so great. And so until people want to use it, we should prioritize what the patient wants, because that's the best way to drive engagement.
Yeah, Abner, and that's a great point. Not to talk too much as a moderator, but take some moderator privilege. I think something that I've talked about a lot about continuing these Medicare, Medicaid flexibilities after COVID is that is a really important part of health equity, because if those go away, it'll go back to how we were before, which is that everybody on private health insurance has access to telehealth services, but then nobody else does. And I think that's a really important point. And then your second point kind of ties into that is, a lot of people will say, we'll wait and see. Not everybody can use telehealth. So should we make it so that the reimbursement policies wait until they catch up, or do we do the policies first and then work to catch up to them? So I think that's a really interesting angle to that issue. You mentioned your plan partners. So I was going to go to Oliver next, specifically, how on this issue of cost and just flexibility in general. Private plans obviously have more ability to be flexible than Medicare and Medicaid, which is dictated by statute. Medicare statutorily required 20% out-of-pocket costs for all Part B services. Can't change that, but can be a little bit more flexible. So can you talk a little bit more, Oliver, about how you can be flexible in kind of adjusting digital health to meet people where they are, as Abner said?
Yeah, I mean, a lot of things thankfully were waived during the pandemic, and people are trying to advocate to ensure, like people said, that things can continue post-pandemic. One example to the video point is, we're able to now do audio-only telehealth visits, which is pretty important for us in our rural communities. We're in a couple of the Rocky Mountain states. It's not necessarily easy to get broadband. And also, there are some individuals who, sometimes seniors who don't want to use video for a variety of reasons. They don't feel they don't feel comfortable using it, and sometimes they don't want people to, be peering into their homes. They want security. So, we've been able to do things like that. One, if I can add on to some Abner's previous point, like one thing that I think is important for public policy to do is, sometimes it can't necessarily shape the market or, what people want, but, one small thing that is pretty vital that was in the American Rescue Plan earlier this year was that there was funding for ONC, which is released grants to the Office of the National Coordinator for Health IT, to partner with historically Black and Latino colleges and universities to train people to diversify, the people who are building the tech. When a lot of this stuff first started, the electronic medical records and stuff that the feds were pushing out, the preference was for patient portals to be on desktops or laptops. It wasn't, people weren't thinking like, oh, we need to create these for cell phones, for smartphones. So having more people involved in developing the technology will help sort of reflect how, people are actually coming into the healthcare system, whether it's virtually or in person.
Great. Thank you, Oliver. There's an interesting question here, April, in the Q&A box, which I thought I could turn to you, and it's around your organizations, how everybody interacts, or what role do patient advocacy organizations play in your organization? And April, I thought maybe you could speak a little bit more to the Telehealth Equity Coalition and how patient advocacy groups are getting involved in that coalition.
Yeah, absolutely. Just if I may, just to add to the last question about, how we can make sure that our public policy is keeping pace with what people actually need. I think there's a lot of questions around whether, Synchronous is the gold standard or not. And I think Abner put it best when he said, a technology doesn't matter if people aren't using it. And so a lot of times we think the alternative to telehealth is in-person care, but for so many populations, it means no care. And so as long as the standard of care can be met, what we're really talking about is patient and provider choice. Some people will want a synchronous visit and they can still seek that out. But for folks where the standard of care can be met, why are we not meeting people where they are? I think that's the theme here. And that's not just having a conversation, but I would argue it means establishing the relationship too. We know some of the waivers have allowed for telehealth visits to happen based on for the patient provider relationship to be established based on a telehealth visit. And I personally hope that's something that continues beyond the pandemic, because it's very important. And if we go back to, I would argue, the 1900s and make people go in person, we're going to lose a lot of people who are now coming to the table. But with respect to patient groups and organizations, yes, we have over 130 organizations with the Telehealth Equity Coalition. We do have patient and provider groups. We have organizations as diverse as like academic institutions like Howard University who are a part of this. We have patient groups like NAMI is also a part of it. Another organization that's a part of our coalition that I always sing their praises. I mention them on every panel that I'm on, is Grapevine Health. If you don't know who they are, you should look them up on LinkedIn now, because the woman who heads that up, Dr. Lisa Fitzpatrick, is a force of nature. And she is, I think, such a pioneer for this concept of meeting people where they are. And so, yeah, ultimately our goal with the Telehealth Coalition isn't to reinvent the wheel. It's to make sure that we are elevating and shining a light and serving as a convener, because especially with respect to telehealth policy, there are different policies for all 50 states. And if we as the community are not communicating, we're not going to be able to share best practices as well. So I can provide a list of some of the organizations that would be helpful as a follow-up to that. And yeah, I think that's just really important to point out.
Great. Thank you, April. And I have an interesting question in the Q&A from our Whova platform, which Caitlin, I thought maybe you could touch on, because we've talked a lot about telehealth and reimbursement for different forms of telehealth and digital health, but there's an interesting question in here around integrated platforms and data sharing and connections with community resources, which we're exploring in some other panels as well. But just getting access to care is one thing. A lot of vulnerable and underserved communities, have a lot of needs that our healthcare system can't address. And so that might be connecting them with community service or a domestic violence shelter, for example. So can you speak to some of the systems that you use at your healthcare system to connect patients with community resources?
Sure, yeah. So for our behavioral health sessions, and I hope I'm understanding this question appropriately or accurately, we use Zoom, the HIPAA compliant Zoom for all of our sessions. And when it comes to connecting clients to outside resources, that is based off of our linkage agreements and who we already have relationships with. So it's pretty easy for us to connect with them already because we have established relationships. Are there other parts of that question I'm missing?
No, I think, well, I guess, is there a certain technology platform that you guys are all using, or is it a digital health solution, or is it more an on the ground, you have relationships and so versus like a platform that you're using?
So thank you for clarifying. So we have to use the IHS platforms. It's not optional. So what we had to do, in order to make telehealth happen was just get clearance from them and get a VPN and things like that. So that was pretty easy because IHS gave us a lot of direction on that. But those we have to use their platforms, period. Yeah, because they're all the same.
And we have some content. If you as an attendee haven't looked at the EHI Resource Center, you should check it out, because we have a lot of webinars and papers where we've had IHS experts on sharing some of the challenges they have around their electronic health record system and interoperability. So there's a question here about, are they using FHIR and standardized tools? I think the answer to that right now is no, but that's the goal. So there's a lot more content on our website about that. So go check our website out. It's a plug for our website. So we just have a couple of minutes left here. But there was a question specifically for you, Abner, around some of the data that you shared on your last slide. And I think one of the attendees was wondering about patient satisfaction scores. Are you all measuring that as well?
Really good question. And yes, we are. So we've been doing it, but here's an interesting thing that has happened. If you look at the Medicare Advantage program, and again, we're doing quite a bit. We're mostly Medicaid today, but our Medicare Advantage business, engagement with Medicare Advantage members is growing. The Medicare Advantage program has changed recently and made member satisfaction a much bigger part of the star rating system. And for anyone, I don't want to get into the details, but basically, if you're Medicare Advantage plan, all you care about is star ratings, and it's a 5-star system, and you want to get to 4, ideally stay above 4, and hopefully get to 5, right? So they've weighted now the star rating system much more for satisfaction. So we've been doing it, but boy, you should see the amount of interest from our Medicare Advantage clients in helping them to improve satisfaction. This is actually a good thing. And I think we should have more of this in Medicaid because, Medicaid, we need to improve the member experience there. And one of the ways to do that is to incentivize the Medicaid plans, just the way the Medicare Advantage plans are being incentivized. So short answer is yes, we're very focused on satisfaction. And it turns out if you treat people like who they are matters, if you engage them in that better way, it's no surprise they like it. The satisfaction scores are higher. People like being treated with respect and that honors who they are, and that treats them not like they're a number, but like they're a person who comes from somewhere, who belongs somewhere, who has a history. If you do that, you will get higher satisfaction.
That's a great point, Abner, and I'm glad that those are coming online as we wait for some more of these measures around health equity specifically to come online and incentivize those who do participate in risk sharing models to take on some more challenging medically complex patients. And I think that's something that we'll touch on again at our SDOH panel at 3 p.m. So thank you all. We are right at time. I want to thank you all for honestly a great panel. I have so many, my colleagues around the table right now are furiously writing down quotes. And so we'll be sharing all of this content on our resource center through the Whova platform and through our social media channels as well. So April, Caitlin, Abner, Oliver, thank you so much. I will share my screen really briefly now to tee up our next panel, which is addressing inequities in health data use, a really great panel led by my colleague, Alice Leiter. So we will all see you. You can click in the Whova app to join our next panel. Thanks so much.
Thanks very much.